Hello and happy Sunday. It's me, Dr. Cindy Duke, medical director, physical director, and there guys, I don't know, tongue-tied today, but medical director, laboratory director, and physician here at the Nevada Fertility Institute. And I'm joining you today, Sunday, April 26th. I have a very special guest joining me today, and we are talking all about coronavirus testing. And I think you're all going to be really excited to hear about this, to talk about this. I know many of you have had questions as we start planning to reopen the economy, get people back to work. The big question is, how are we going to know that it's safe? How do we know it's time? How do we know that the society is ready and prepared for another outbreak? And so joining me today is my guest and friend and colleague, Dr. Erik McLaughlin. Hi, Doc. Now, it seems that we're freezing, which is odd. Let's fix this. Okay, Dr. Erik, I'm back.
All right. Welcome back.
He tries to work against us sometimes. It looks like our viewers are still there, so thank you everybody for waiting. I'm actually going to just restart us while we're here. That way we can just go from scratch again. Okay, everybody? So just stay with us. Doing it again. It might be that then. Hi, everybody. There we go again. How? Okay, we're not going to do anything fancy. We're just going to do it. So, right. Hey, everybody. Happy Sunday. I'm Dr. Cindy Duke, medical director, laboratory director, and physician here at the Nevada Fertility Institute. We are finally able to get going with our Sunday program. I have with me Dr. Erik McLaughlin, and it's a treat to have you today, Doc. Welcome, welcome, welcome.
Thank you very much for inviting me.
Is it okay if I called you Dr. Erik?
That works just great for me. Thank you.
Awesome. So guys, I know Dr. Erik because we're actually colleagues and part of a group that he started looking specifically at COVID-19 and looking at the epidemiology, the testing, the research, and the science focused on that really, and how the science can be used to inform the clinical aspects of how we deliver care. But Dr. Erik, you're also super, super special and talented because you have done so many different things in terms of how you crafted your physician career. Do you want to tell us a little bit about who you are and what you do outside of the pandemic?
Yeah, sure. So I'm a specialist in family and emergency medicine. I have an MPH in global health, and I work chiefly as a chief medical officer and kind of a consultant on a lot of what I call healthcare system strengthening and building these healthcare delivery machines domestically and overseas. And before I was a doctor, I was actually a firefighter and an EMT, but carrying all that hose up and down the stairs got really heavy. So I really enjoyed medicine, and I got encouraged to go on and study in a different arena, and really just fell in love with medicine and helping people out.
And what do you do outside of medicine?
Outside of medicine, I am a proud father of twins, Leo and Athena, and I'm a husband. And I also like trail running and riding mountain bikes and rock climbing. And I study a lot. I read an awful lot. You know, we're always reading, and especially now, there's a lot of new stuff to learn. So those are usually what take up the brunt of my time is family, a little bit of exercise in the mountains, and just studying new information. Always reading. Always reading.
You really are a fan of information. In terms of your family, how are they coping with the whole pandemic? How are you guys making do with this?
Good. We're doing well. You know, as a family, we're kind of a nomadic group. We kind of move around a lot, and you know, the ability to stay put in one place is kind of nice for us. It's a bit of a change. And my wife and I, we both work from home, so for us, it's not a real big change, other than I'm not on an airplane 3 times a month, flying to different locations. Our twins are homeschooled now. Leo and Athena are in homeschool, which is great. Our school has been very supportive, setting up, you know, learning platforms and things for them, which is wonderful. And we're trying to have, you know, a semblance of a very normal life. Fortunately, we are doing great, a lot better than most, I believe. We've got a lot of people that help support us, bringing food deliveries in. And there's a real big community effort to keep people home and safe and healthy, and hopefully happy as well.
Happy as well. Indeed. And in terms of your family, trying to figure out this echo that's returned, do you see anything in particular that, for people who are listening right now and they're wondering, okay, so we're getting ready to reopen the economy. What about my children? What about my family? Are these questions that you are asking as well?
Yeah, you know, I think these are questions every concerned parent or every person with an elderly person in their family needs to be concerned about. Every family has their own different appetite for risk. Every family has their own unique demographics. If you are maybe not benefiting from having grandparents or great-grandparents in your immediate nucleic family, well, then, you know, you may be a little bit more able to tolerate the risk. If you have kids, we know kids do pretty darn good in this, thank goodness. So you may have a little bit more risk appetite to resume a little bit more going out adventure, as I say in our family. But these are questions that I think every individual family has to answer based on their own profile of who lives in the house, what do you want to do, and there's risk rewards for everything.
Yeah. Speaking of, a big part and the concern that we all have is testing, right? Are we testing? And are we testing enough? And how do we test? And that's really why I invited you today, because I know you are an expert in tests, validations of testing, and how to test. 1 second. So for those who are joining us, this is me, Dr. Cindy Duke, and my guest, Dr. Erik, and we're talking all about coronavirus testing. I see people saying, I have questions to ask. Go ahead and write your questions down below for us, and we will answer them as we go along, I promise. Dr. Erik has time. He has committed to staying here here and answering your questions. So go ahead, put your questions there, and we will get to them, I promise. But as we start, tell us, first of all, why do we need to test for coronavirus? There are people out there who are saying we're making a big deal. What is testing and why?
You know, we had a saying when I trained in public health. It's that if you're not testing it, it's not really happening. Mm-hmm. We can't really tell. The analogy I give to people when I talk to them is, I want you to imagine yourself in a dark room and it's pitch black. You can't see anything, and you feel the surface of a table, and you're in the center of that table, and you can't tell if that table is 10 feet wide by 5 foot long. You can't see how big that table is. You can only go by feel, and you feel just that surface, and you keep feeling around until you get to an edge, and you've got an edge, and then you run your fingers along that edge until you get to a corner. And that corner now is, you're starting to get your arms around this problem. Our fingers touching that tabletop are our testing. And without this, we don't know how big of a monster we're fighting. We don't know how scary it is. We don't know, are we going to stumble over it in the dark, or is it just a tiny little place that I can just set my drink on and not worry about? So we need to measure that table size.
So testing,
vital.
It seems like here in the United States, we need to do a better job of testing.
Yeah, you know, testing is important. I think testing is the cornerstone of one of the pillars of public health. Again, if you're not testing it, you can't prove it. You can't prove that it's bad. You can't prove that it's good. But we need to prove this is high fatality rates, a low fatality rate, high prevalence in the community, not a lot of prevalence in the community. And the way we do this is testing. You know, you look at some other countries that seem to be doing better on their responses to this epidemic and this pandemic. And it all centers around a very robust testing platform. You know, you look at countries like South Korea, you look at Italy, places like this where they are really penetrating into their community, and they're really able to test a variety of ways, and they're making it easy to get tested. You've got to bring the mountain to Muhammad, so to speak, rather than trying to get people out. You've got to make it easy to test.
Yes.
And you need to have a lot of testing everywhere. I think certain areas require more testing depending on the activity and the tempo of the disease and their geographic region. Mm-hmm. But you need to be testing a lot of areas. This is the cornerstone of good public health. You know, there's a lot of ways to track if we're testing good or not. You can look at just the sheer number of tests. Mm-hmm. You know, we're doing 50 tests a week. Well, that's good if you've only got 50 people in your region. If you're doing 50 million tests a week, well, that could be bad if you have an enormous global population. So raw number of tests is good, but that doesn't always give you a fair bias based on the population of the people that you're testing as a community. Yeah. Well, then you can also, I'm sorry, go ahead.
No, I was going to say, speaking of that, so like here in the United States, there are 330 million of us. Mm-hmm. How many of us should we be testing of the 330 million? If you look at state to state, given that different states have different populations, is there like a percentage that we should be shooting for to really have a sense of what's going on in our community?
Yes. Yeah, there is, you know, and these are numbers based on past epidemic knowledge that we've learned from previous outbreaks in various locations around the world throughout, you know, from public health growing up from cholera wells in London to where we are today. And a good general number that I'm seeing and I'm starting to feel comfortable with is around 2 to 3% of your population. And I think that's a good number to kind of shoot for. You know, you look at countries like Italy, Korea, they're in the 2 to 3% range of who they're testing. And that's a good number to aim for. I think the US right now is coming in at around a hair under 1%. Of our testing. We're coming in around 0.008 roughly on the number of people that we're testing of our population. There's another statistic that I like to look at that is, I believe, a little bit more accurate, is you want to have a lot of positives, but you only want 10% of your positives. Yeah. So if I'm testing 10 people, I only want one of those people to be positive. I want my other 9 to be negative, because that means I'm casting such a wide net out there that I'm finding the edge of that table, and I know where the squares are, and I can then start drilling down on my sick people. So that goal of 10% of your test being positive is also a very, very important number that I think we're going to start to see a lot more of in the future.
in the future. Well, right now, clearly, we are under testing.
Yes, sir. Yes, ma'am, we are.
Yeah.
Yes, we are. We are under testing.
Because, now you can see the ticker scrolling across on the bottom, and a lot of people have been focused on that and said, well, clearly the United States is testing a lot of people. But what you're sharing now is, if we're aiming for 2 to 3%, 2 to 3% of 330 million is somewhere around 6 million to almost 10 million people. So we still have a long ways to go in terms of tests. We do.
And looking at that percentage of positives and in your total group that you're testing, New York City, a hot spot in this here domestically in the US, they're having 20 to 30% of the people that they're testing are still coming back positive. So you need to amplify that testing circle and test more to get down around that 10% range. I believe Italy's coming in, they're testing now and they're getting around 8% of their positives, which is good. They've got a good idea who's sick and who's not sick. And that's really our goal right now.
And the whole goal of testing is so we can have containment, right? We don't know if we're containing things if we haven't tested enough people to assess the rate of spread.
Yeah. Again, if you're not testing it, you can't measure it. So I would be interested specifically in knowing who's sick now, who is at risk for getting sick. And I'm really, really interested in who was sick 2 weeks ago and is now better. Because as we start.
How do we test that and just make that distinction? What kind of tests are there for that?
So there's a couple different tests that we can look at. To me, I use 3 main types of tests in my analysis of work. You've got NAAT tests, or nucleoside, nucleic acid amplification tests.
Yeah.
This is kind of the classic swab in the nose. You've got a rapid agent test that is kind of like the strep throat swab that everybody knows of, that gives the classic plus or minus, yes or no, like a pregnancy test.
Yes.
And then you've got these serology or antibody tests. The antibody tests are very cool because they can tell you if you've got it and you're sick now, or if you've had it and you've got maybe a little bit of immunity to it, or if you've had it and cleared it and you were thinking, wow, I never even had any symptoms at all.
Right.
That's very interesting. So I think you need a mosaic pattern of all 3 of these and use them at the right times and the right locations. But typically the nucleic acid tests and the serology tests are your 2 biggest players that you're going to want to pay attention to, I believe.
And so that NAAT test, is that the same as a PCR or the polymerase chain reaction that people are hearing and learning about and seeing in popular media?
Yeah, they are. They're a PCR, polymerase chain reaction, is a way to take a small amount of DNA, or in this case, RNA from the virus. And I know I'm also talking to a virology expert, so you mind me, please, ma'am. But you take that swab, and it's got a little bit of the virus's RNA particles, like DNA, but it's just a virus. So this one uses RNA. Yeah. So you've got a little bit of that virus particle on that swab from the nose or the back of the throat. And you use PCR to make more and more copies of it. You take 1 or 2 and you grow it into 20,000, and then you test those copies. So it is kind of, the way I think of it is making a copy of one bad monster a million times over, so it's easier to count them.
Count it.
That's how that plays into consideration.
So you said that's the nasopharyngeal swab. What is that? And somebody's actually asking, why does the test burn? Is that the test that burns?
Anytime you stick a swab in the back of my throat through my nose, it's going to burn. I've had it done. It's not pleasant. You're getting deep. You're going in through the nose to the back of the head, in the back of the posterior oropharynx. It's an invasive test. It's not pleasant. I wouldn't want to do it for fun. And it typically triggers these eyes. You get lacrimation because all these nerve endings are kind of really close congested in your head. So you're scraping all these things, and it's an unpleasant test, but it gives a lot of vital information. Sadly, there's been a lot of literature coming out recently that really shows that nasal pharyngeal swab in the back of the throat is better than just in the back of the throat, like a strep throat swab test. So unfortunately, and then you've got an even deeper test where you can do it into the lung, and that gives better results. But man, the more invasive you get, the better your sample. But, I don't really want a swab stuck that deep into my body if I'm, unable to avoid it.
So sunflower oil, Why does the test burn, make your eyes run water, and make you cough after? This was my experience after getting the test done. So it sounds like that's exactly what you're describing, Dr. Erik.
Yeah, what you're doing is this is going in through your nose into the back where your nose and your mouth meet in the back of your posterior oropharynx. That's why sometimes when you go, you can get snot into your mouth. It's that communication back there that you're going into. It's invasive, and you're triggering oftentimes a gag reflex. So you get that involuntary retching, which causes lacrimation and that whole kind of catecholamine release of fight or flight, because something invasive is deep down in your airway and your body's trained to push it out.
Yeah.
So that's a healthy body's response to a crazy test.
You alluded to some tests being better than others. What do you mean by better? What makes it better?
Good question. Better means higher rates of true positives and lesser rates of false negatives. So what we're looking at is there's this concept that we talk about in epidemiology called sensitivity and specificity. And this basically talks about people who really have the disease and the test confirms they have the disease. You're not getting false positives. And then you've got sensitivity that looks at negatives in the disease, and you want to avoid false negatives. So we want that sweet spot of both, that tests somebody that shows, yes, he has the disease and the test proves it, or no, she doesn't have the disease and the test proves she doesn't have it. The swabs from the nasal pharynx are the best. They have the highest sense and spin for both.
Oh, no. So that means then we're not really close to being able to test just saliva or just blood to look for active infection, huh?
So there are some tests out there now. Everybody hopefully is familiar with the FDA, the Food and Drug Administration. They monitor and kind of give guidance on testing. They have a thing called an EUA, Emergency Use Authorization. This is kind of their stamp that says the test is met their standards and it's good to go. Now, you don't have to have an EUA by the FDA, a lot of abbreviations, to start administering your test to people. But what we're looking at is the difficulty in creating a test. We're looking at the difficulty of, how invasive of a test is it? How quickly can we get the results? And I think it was last week, a saliva test came onto the market by a commercial laboratory that amplifies DNA or RNA in this case, and allows you to do the same type of testing. That's a lot easier. I think you're going to have better compliance. If you ask people to show up and you're going to get a stick shoved down the back of your nose, or you can spit in a tube, I'm going to spit in the tube every time, but you have to weigh this off with the efficacy and validity of your test. So I think that's important.
Yeah. And how efficacious or valid is that particular test? Do we know the saliva one so far?
It's not as good as a nasopharyngeal test, sadly. The nasopharyngeal test is, and I'm not even going to use the term gold standard. The nasopharyngeal test is one of the best tests we have out there, but compared to a test for HIV, or compared to a test for HPV, or some of these other viruses that we're used to dealing with, we're light years away from getting a good quality test in a responsible amount of time that people are going to saddle up and take.
Yeah. Does that mean if somebody has a high suspicion for being infected, and even the nasal pharyngeal swab is negative, they should still presume they're positive?
Yes. There's a high rate of false negatives. I'm not going to mention the specific manufacturer of a test that's widely used right now, but they're having a much higher rate in real life clinical scenarios when you're getting tested in the ED or your urgent care or your family doctor's clinic. They're seeing more false negatives than were originally expected when the test rolled out. And that's unfortunate because it gives a little bit of false security. It gives a little bit of ideas that, I don't have it, and maybe I can go out and do other things. And that gets into a dangerous area. False negatives are just as bad as false positives.
Yeah.
And this test is seeing a lot more false negatives. One of the beliefs behind this is it's a little bit user dependent of how deep are you able to get that into the oropharynx. If you just stick it in the anterior part of the nares right there, well, you're not going to get as good a sample as if you get it all the way back in there deep. So a lot has to do with the validity and experience of the person doing the test and how compliant the person is. If they pull their head back in the middle of it,
right.
Yeah. You know,
So,
that brings me to another good point about, you know, the idea of the number of tests performed aren't always the number of individuals getting tested. So, and I don't mean to play with words, and I'm not a lawyer, but if you're doing 50,000 tests a day, you can only be testing 5 individuals, or vice versa. So the number of tests done doesn't mean you're testing all individuals with that same frequency and number. So I think that's an important distinction as well, man.
Meaning some people can end up getting the test more than once.
Yes. You know, and sadly, as we're learning about this, you know, you're seeing people that, I got tested 3 times and they were all negatives. And then when I was intubated and put into an ICU, that's when my 4th test became positive.
Yes.
Would have been nice to have known that a little bit ahead of time. And those false negatives and false positives are really playing havoc. We're struggling to get a quality test.
Yeah. So what would be a quality test? And if, for example, that nuclear amplification test has this false negative rate, does it make sense to combine that with what you described earlier, the serology or the antigen test? Is there benefit to combining them?
You're thinking like an epidemiologist now, doctor. I love it.
I've been watching you and listening to you long enough.
So we like these 2-step tests. You know, we like using a quick rapid point of care test that I can get, ideally in a perfect world for me. We'd have a test result that's simple, easy to do. We do the nucleic acid amplification, and we get a test that is a pretty good specificity and a pretty good sensitivity. So we've got a fair rate of true positives and a pretty low rate of false negatives. That's a good screening test. But then we usually like with ELISAs and Western blots, for example, with, I'm going to say syphilis. Okay. We want to do a screening test, and then we want to confirm that, like with HIV. Okay. So we want to do a test that screens, and we can throw a big blanket out over the community on, and then confirm this with our serology testing. Serology testing is incredible. The technology is amazing. This is not testing the antigen or the virus particle. This is testing my own body's immune response to having fought the virus sometime in my past. And we look at these little things, they're called immunoglobulins, and you're going to hear people talk about IgG and IgM. Right. All right. When I was in med school, my last name is McLaughlin, so I remembered IgM is the biggest one, and it's the one that fights the first. Yes. I like to think of that in me, right? I'm modest. I like it. So IgM, you see in the serology test, your IgM will peak high in the beginning phase of your illness and then drop off. And then as you start to recover, your IgG goes up. And the IgG can be used very excitingly to look back and see, like when I was a kid, I had chicken pox. I'm old enough that I actually got chicken pox. I have, or I should have, an IgG titer in my body that proves biologically Erik fought the chickenpox virus when he was a boy. Now that gives a world of new information to us, ma'am.
Yes. And so speaking of which, to my knowledge so far, the FDA hasn't really approved a serology test yet there are lots of tests out there on the market. How are they working, and do you see any so far, without naming names per se? Are there any antibody tests out there in the market that you now think are, up to par for what we're looking for from them?
Yes, I think there are. These are, as a scientist, I like yes or no. I like positives or negatives. I like the demonstration of there are IgG titers, and I want to see how high they are, and I can measure those. There are tests out there that are able to do this. They're cumbersome, they're awkward to roll out, and this is what we're fighting now, is getting this technology everywhere. There are some tests out there. World Health Organization is another body, because I practice globally. World Health Organization is another body that I follow, and I look at their literature, and they are advising screening with NAATs, and then using your real-time PCR to amplify this, and then I'm expecting them very shortly to come in and say that you're going to confirm this with your serologies, your IgGs and your IgMs. And I see us going that way. Sadly, here we just lack both tests. We need.
What is that? Why is it that the world does this that we don't?
That's a good question. That's probably a question more for someone that's in an elected official capacity. For me as a doctor, I want tests. I want them for patients that need them. I want them for patients that maybe not need them, so we can better understand how big that table size is in the room.
Yeah.
There were a lot of complexities in developing a test like this. We previously had a good nasal amplification test that we were able to run like a panel of respiratory viruses that we typically run in the emergency departments. And that gives us a good broad example of, you have influenza A, influenza B, influenza B, RSV, human metapneumovirus, a couple of the flavors of the other coronaviruses that make people sick each year, rhinoviruses, things like this. This was a new bug. This was a new virus that we struggled to get. There were complications with some of the federal testing entities that rolled out with reagents, because you don't just swab the test and it magically tells you your answer. You have to put some other chemicals on the test, let it cook, kind of like baking a cake, and get your results at the end of it. And you have to have good quality chemicals you put on your swab, good quality sugar, flour, water. It all goes into getting a cake with a valid result. And if one of your steps in that test is off, the whole thing has gone to pear-shaped.
So what I noticed, in order for New York to get a handle on this, actually the governor of New York went ahead and said private labs can test, as opposed to the initial protocol, which involved only state and federal labs, right?
Yes. Yeah.
Why was that? And why was that a necessary step? Or like what we're seeing now, which is the state of Maryland, the governor went ahead and secured 500,000 tests from South Korea.
Yeah.
Why is that happening in the United States?
I think that's a case of governors really wanting to do the best for their people and their citizens. And they're listening to their public health experts and their physicians and their scientists, and they're seeing the need for testing. And if I can't get the brand of bread that I like to get at one supermarket, I go to another and I get that brand of bread, or I get that item that I need. And if I can't get it from one shop, I go to another shop. And I would really like to see a robust federal leadership on this, with clear guidelines on these tests are going to be the ones we use, and these are the ones that are our backups, and we've got enough testing for everybody. But we don't have that. So you're seeing this patchwork quilt being developed of tests coming in from South Korea to Maryland, or a commercial lab that's stepping up and giving tests to through their commercial sites, their storefronts in certain regions. And by hook or crook, we're going to get the testing that we need. It's just coming together, like I said, in more of a patchwork network rather than a unified response.
So now validation, I know you study testing validation a lot. How do we validate all these different entities, or is that not a concern here?
That is a concern, because you don't want this to turn into the wild, wild west. You don't want me and my mom cooking up our own test and then selling it on eBay or Amazon because that again is irresponsible, because you're going to have false negatives and false positives. Yeah. So this goes back to there's two entities that I really enjoy reading their literature from. One is the FDA, and they have an ability to kind of waive some of these fastidious testing guidelines that they have to put the tests through. The tests themselves have to be tested before they're rolled out into the general public.
Right.
So they have the ability to do what's called an EUA, emergency use authorization. That is a quick sample test. If it does all right, then they approve it with an EUA and it gets rolled out to the public. There's also another accrediting or regulatory body called CLIA.
Yes.
This is a great group. These people look at what kind of tests are suitable to be performed where and how accurate these tests are. So you've got CLIA, which is what is it, clinical laboratory information analysis, I believe, or analytics.
I'm actually a lab director.
There you go. I'm sorry, I don't know the name. I should. We just call it CLIA. But you've got CLIA that really accredits all these tests and these bodies, and they say this test is an easier test to do, perform, and interpret. So you don't need as robust a training, meaning you can have more lay people administer the tests,
Yes.
which obviously makes it get out into the community easier. And then at the highest level on the CLIA, you've got to have, board certified pathologists that run a very strict, tight lab and all these regulations and inspections. So you've got this gambit in between those levels. And I think they do a wonderful job of really demonstrating to people the levels of the tests, who can perform them, and they validate. And their stamp means a lot to me. I think they do good work.
So basically what you're saying is, if someone, maybe they're a private practice doctor or they run a surgery center and they're thinking of doing serology, one of the things they should consider is looking at CLIA's list of approved tests or CLIA endorsed tests as a way forward.
Absolutely. I think if you're going to do it, you want to go with people that have already validated your test. You want to get what you pay for. You don't want to get a knockoff test that, is just Kool-Aid and a swab. You want to get what you're paying for. Your patients deserve this. The community deserves this. So I think they do a great job. And, I was on their website earlier today looking, and they've got a laundry list of approved tests, manufacturers, where to buy them and how to get them. And that's awesome. The FDA has something similar to that. The CDC has something similar to this that really is bringing the ability for that family doctor, that private practice physician, to reach out and say, all right, I'm going to buy some tests and I'm going to start testing my people in my panel. And I think that's awesome.
That's awesome. And I think that's important because I feel like that's one of the concerns I keep hearing from a lot of my colleagues, which is, I really want to know more. But I feel like, especially when it comes to serology, what you're hearing from a lot of doctors out there is, how do I know which antibody test to choose? And what do I do with that information? And how do I find the information? Because there are a lot of companies already doing direct marketing to doctors and practices who are saying, use our test, use this, use that. But of course, as everyday clinicians who aren't studying epidemiology the way you do, their worry is, how do I know I'm picking the right test? Or it may be someone in a country far away who's also interested, no science background, but the public health interest is there. And they're wondering, how do I go about finding tests that we can use? And so I think this is really important information, and I'm glad you're able to discuss it with us, because that's so important. So you're saying, go to the website, they even tell you the skill level that's needed.
Yes, it's wonderful. You can go, you can visit, and you can look at, they're called CLIA waived, for humble doctors like myself. These are the tests that we typically do, in an outpatient clinic or things like that, point of care at the bedside or in the clinic. And these are going to be meeting their stringent standards. And like I said, it's threatening to get into the Wild West, where you have these tests that are out there that haven't been evaluated by these accrediting bodies. And I think with that, you have a real caveat emptor, buyer beware, because, the worst thing you can do to your patient is perform a test on them that has no clinical significance.
Right.
You've put the patient at risk of a test. You've taken time, you've taken money, and you don't have any actionable information usable at the end of your exam and your testing period. So that, I think, it's better to do nothing than use an improper test. And I think that the guidelines of where to get those good tests can be found on that website. Definitely. Yes.
I agree with you. And you just mentioned something that a lot of people are also interested in, which is that point of care or rapid testing. What's that? And is that different from serology and the NAAT tests? And how so? Yeah,
so these are, these are your I call them RADTs, rapid antigen detection tests. Most everybody has probably seen this. I think probably the most common one is that rapid strep swab that we do so much of in our pediatric populations. You go back, you tickle the tonsils, and then you get the classic plus or minus, the yes or the no. You get like similar to a pregnancy test. So these look at antigens. Antigens are what is signaling your body to attack something. So this is kind of like putting a laser to guide your immune system to attack this. You're looking for the antigens released by this virus, and you're testing those. Now, the World Health Organization has been clear that they're not on board with using these clinically yet. They are advising these for research purposes only, just because I think they're trying to validate them with the NAATs and the serology testing, kind of bookending the problem and then finalizing the validity on this. So if you have the rapid antigen detection test is the game changer. That is the swab. 5 minutes later, plus or minus, and you're good to go. Yeah. But these are also sometimes the most complex because there is no gray area. It's either the black or the white. Right. But that's a holy grail.
Isn't one of those already approved in the U.S.? What is that test, the EUA, that got an EUA about a month ago?
Yeah. So this is approved and it's being used right now. My take on this is that the specificity and sensitivity isn't there yet, which is why, again, I side with the World Health Organization that you need to do that two-step confirmation, or you need to do it in conjunction with a research protocol, meaning you are a university or a medical system, and you're doing your test, but then you're backstopping it with one that has a higher rate of true positives or false negatives that can confirm, yes, it's there. And then you report this data back, because the people that are manufacturing these tests, the scientists, those virologists, those immunologists, they're always tweaking this test and trying to build that better tomato. Yes. So they need this information, and it's not there yet. It's close. I'm hoping in the next month or two, we're gonna get some more EUAs coming out, but I don't believe it's there yet as a mono test alone.
And that's the thing about antigens. Oftentimes proteins or carbohydrates being produced from the virus, as the virus mutates, these protein structure can mutate, and their amino acid makeup can mutate or change, and that can change the sensitivity and specificity. So I agree with you. I wanted to hear your take on it, because that's been my take on the rapid point of care, and why for me in my clinic, I have declined bringing it in, because even though it's available to some who are CLIA directors, I don't see how I can use it and be relying on it, especially not just for telling my patients they're negative, but for me as the doctor, being sure that my patient is negative and I'm not now exposing myself because of a test that I did that said they're negative.
Exactly. It's a holy grail, and it would be a big game changer. I don't think the technology's there. I liken it to, riding on a horse and trying to throw something into a bucket on another moving horse. Yes. So there's a lot of coordination that has to happen, and it's coming. It's going to be there. I'm very confident in the scientists. It's just, I don't think it's quite there yet. That's why those nucleic acid amplifications and the serologies are going to be your two big players right now. But those are your bookends, like I said, to help get that rapid antigen test developed.
So for now, if you guys are listening, what Dr. Erik is saying, the nasopharyngeal swab is going to be here for a while yet, right? So you don't get to show up and tell them, I don't want that one, do something else. If you really want to know if you're positive or negative, you have the best chance of knowing from the nasopharyngeal swab.
Yes,
the first time around. And, so speaking of that, it seems to me that for a lot of people and a lot of the things that we've been following, there are now, and this could just be anecdotal or even conspiracy theories, but there are people claiming that some people get better testing than others, that good tests are available to some people, celebrities are getting tested when likewise, they're suggesting that maybe certain ethnic minorities are not being availed testing. Have you seen any information? I know you're reading a lot of the data, you're summarizing it, you're writing summaries on these. Have you seen any actual hard facts or evidence of any of those things happening?
I haven't seen, we have a colleague in common that is a PhD epidemiologist, and she's a brilliant scientist. And she and I scour the literature looking for good quality literature. And as you said, there's a lot of anecdotal evidence, from commercial media sites that as a scientist, I can't back. I hear a lot of anecdotal things. I do believe that there are certain groups of people, certain communities that are probably getting under-tested, but this is moving fast, and it's tough to get a beat on something right now. And what we're seeing, I believe, is a disparity in testing. That if you have access and money, you may have a greater chance of getting a test. I have a little bit of means. I'm very fortunate. And I'm fairly certain if I wanted to get my family tested, I could spend money and go somewhere and get it tested. I think that's a very dangerous fallacy that, the virus, as far as I'm concerned, doesn't really know what zip code and how much income you make, doesn't really care about your skin color. It's out to kill humans. And I think that, again, this goes back to that same drum I'm beating. We need more testing across the boards for every community, for every group. We just need to be testing a lot more of everybody.
Mm-hmm. If you had to choose a test today to test yourself and your family, if you needed a test and somebody was like, Dr. Erik, you get to pick which tests you and your family get done today, what would you pick?
I do the nasopharyngeal swab. I take the deep swab test. If I were sick, if I had symptoms and I needed to know, if my little boy or my little girl were sick, or my wife or my mom, I would nasopharyngeal swab them. And then I would also want to know IgG. Because to me, that's very important. I had it maybe 3 weeks ago, and I had a little bit of a runny nose that lasted for about 3 hours. And then I woke up the next day and it was fine. We're seeing that could have been a COVID exposure. We're seeing that could have actually been SARS-CoV-2 right there in my body. And I just didn't produce a very big clinical reaction or response to that virus. Now, the big question is, do I have immunity to it?
Right.
Am I able to get it again? Am I able to give it to somebody else? So I think it's important to know, do I have it now with my fever, chills, and cough? And I think it's also important to know, was I one of the people in February when I was walking around in the casinos in Las Vegas with my family, having ice cream and doing fun stuff? Did we have an exposure and we just clinically cleared it mildly?
And a lot of us think we were exposed, don't we? I haven't seen anybody actually survey people to ask them how many of you think you were exposed. But in my informal surveys of family, friends, and Facebook, lots of people telling stories of feeling quite sick in December, January, February, or even going to the ER and having that multi-swab that you've described that came back negative, but they had all these classic symptoms.
Yeah. I hear reports of this. We look at the first case in the U.S. being early January in Seattle that's documented.
Yes.
You look at reports now in the literature coming out of the original case mid to late November in China, in Wuhan.
Yes.
And you look and you see that this is a little bit more prevalent in the community than we see. And it kind of bubbles under the surface. I don't know how far back I would take it chronologically, but I'm of a believer, and I subscribe to the idea that if you were sick, I would say in end of January, February, Marchish, with these types of symptoms, it very well could have been. And I'm going to challenge something else: is even if you weren't sick, you could have had an exposure.
Yes.
This is what's very interesting to me is, from a personal anecdote, my family and I, we were sick between Christmas and New Year's, and everybody in my family got it, but myself and my father-in-law. He and I had very minor symptoms, but the rest of our family got very, very sick. I'm not saying that was COVID by any means,
right,
but I'm saying that different people get affected in different ways by the same virus.
Yeah.
So, I could have had it and I had no symptoms and I didn't know. And that's what is so lethal about the virulence involving this disease, is that I could have it and be carrying it around and spreading it like Christmas cheer to people that I don't even know I'm aware that I have it. So that's why the IgG test of knowing who's had it and who hasn't is going to be so vital, I think, going forward for us.
I think so. And I think as someone with a practice, that's how I feel, especially as an OBGYN. In OBGYN, we test a lot of people for exposure to different things: syphilis, hepatitis B, hepatitis C, HIV. I think COVID, coronavirus, SARS-CoV-2 exposure is going to become one of those key things so that we can know two things, like you alluded to earlier, which is even if our patients are asymptomatic, and now the tests being done at labor and deliveries, et cetera, are suggesting that up to 30, 40% of pregnant women are showing up to labor and delivery positive for the virus but asymptomatic. I
Yes.
want to know with my patients, even before I get them pregnant, so I can tell them, you know what, you've been exposed, so you likely had it before. They might even be an asymptomatic carrier, unless we're doing the NAAT, a nasopharyngeal swab. We won't know if they're an active asymptomatic carrier, but we'll at least know if they're exposed. Although some people say if you're active but asymptomatic, IgM should be high.
Yes.
So we'll see that. That would help us. But certainly, who I'm especially concerned for are the ones who are going to be negative. No antibody.
Yes. They are truly naive.
Yeah.
And I don't mean that in a social sense, but I mean in a physical, biological sense.
They're at risk for infection.
They're the ones that can get it. They have the open door with no security around them, so to speak. It raises interesting questions about the potential in the future of what are you allowed to do if you demonstrate an IgG positive titer? Are you allowed to have more freedom or relaxed measures to keep you confined? It raises a lot of interesting questions because that is protection, we believe. But again, I've yet to see really clear documentation that just because I've had it once doesn't mean I can have it again.
We don't. And there's some emerging data that suggests people may be re-exposed and reinfected. Have you seen any papers that tell us from serology how many people are negative, meaning how many people are still not part of the herd of positive IgG?
With regard to the number of people that have it but are still remaining asymptomatic?
No, actually don't have it asymptomatic, but don't have any antibodies, not IgG, not IgM.
So you're talking about just raw prevalence in the community.
Yeah.
We're looking at a lot of epidemiology models, and I'm fortunate that I get to work with some awesome colleagues who are they're biostatisticians and they're math geeks. And they're awesome at what they do, and they create these models.
Nice.
And if you take the number of people that are positive, well, the other side of that is the people that are negative.
Yes.
And that then leaves your population at risk. So we look at these things called relative risk indexes, and without getting too much into the math behind that, you start to look at what is their chance of being infected. What is the vulnerable population in my community? And I think right now, with a lack of good IgG testing, we need to start assuming that is a high prevalence or a high number of people in the community. So I think you're going to start seeing, like, you look at this great paper that came out of Santa Clara, California, where they were seeing large numbers of people having titers against the virus. You start to then need to drill down a little bit more. Was this actually SARS-CoV-2?
Yes.
Or was this another family-related coronavirus that has a similar antibody that just crossed over that our test is picking up? So what you're seeing, exactly, a false positive that shows he has a previous coronavirus fight in his history, but was it this specific SARS-CoV-2? So that is going to be very important. And I think we're still teasing this out.
Yeah.
I personally believe that we're seeing, I would estimate around 30% prevalence in the communities right now that are having a really active tempo of the virus spread.
Yes. And then if it's 30% prevalence, that still means that large outbreaks are possible.
Sadly, yes. You talk about herd immunity, and that's a big thing that we like to talk about when it comes to vaccines. It's like measles vaccines and things like this. That's the basic idea of, I'm not going to get sick because everybody around me has protection. It's like a ring of healthy, protected people around me, keeping me, the vulnerable person, protected. To get true herd immunity, you need to be having good documentation, one, that you can't get reinfected, and two, you're starting to look at 75, 80% of the population even having antibodies or a vaccine in some form to stop transmission of that virus. And that's a big number.
In virology, we say 80%. You need minimum 80% to claim herd immunity. So if the prevalence is more 30, 40%, and we're starting to talk about opening up the country, and we're telling people the curve is flattened and spread has happened, is that true? Now that we know the prevalence and that, up to 70% of people are still at risk of being infected. Are these numbers true that we're actually either flattening the curve or on the downward swing, as we're now starting to hear in the popular media and amongst some of our governing bodies? No, that's the $1 million question. I think, to me, we look at these epidemiology curves, and the curve comes up, and we've got a rapid up slope of sick people, more and more getting sicker, and everybody kind of assumes that curve is going to point back down. And a lot of the modeling that I respect shows that curve looking a little bit more sadly like this. Yes.
That we're going to have our infected people. And in epidemiology, we talk about doubling rates. When you go from 2 cases to 4 cases to 8, and it doubles. And how many days does it take to double?
Yes.
So when you've got, Northern Italy, when they were really humming, they were having a doubling of deaths and new cases every 3 days, roughly.
Yes.
That's a lot. They were going from 1,000 to 2,000 to 4,000. That's scary. That's a lot. That's scary.
I mean, it was logarithmic.
It was logarithmic, exactly.
Yeah.
So that doubling, according to the modeling that I respect, that doubling doesn't go away. That doubling decreases in duration. So what you've got is, instead of doubling every 3 days, you're doubling maybe every 18 or 20 days. But you're still doubling. The cases are still rising. The cases are still increasing. You're flattening the curve, but you're not dropping the curve. Yeah. And I like some of the recent guidelines from Dr. B and Dr. F that speak, very brilliant physicians, and they were talking about some of these guidelines for reopening about demonstrable decreases in cases over a period of time.
Yes.
I'd love to see some decreases in cases. What we're seeing now is decreases of incidence of new cases.
Yes.
I'd love to start seeing a lot more drop in these cases. I think that's going to take a lot longer time, unfortunately. And
so would you just open up the country now? Would you keep it closed till September? What would you do?
I think that you're going to have, I call them spot fires. Okay, is that you're going to have pockets of endemicity and pockets of outbreaks where New York City, New Orleans, I went to Tulane, poor New Orleans right now is getting hit hard. You've got Washington with there was the first big outbreak in the nursing home. So you're having these fires around the country. There are other areas, I believe, that may be able to demonstrate this. They can do, if you've got quality testing, and you can show decent low transmission, low infectivity, low prevalence of the disease turning over, I don't think that that's unrealistic to start exploring ideas of opening. But there are certain areas that, again, if you're not testing it, you can't prove it.
Right.
So I really want to see people testing. And with this, you can't get it wrong. You can't afford to get it wrong because you can't take it back. That's why I think it's so important to have a robust testing program like Santa Clara did. I applaud them for that. And then you can have an idea of how big that table is, and then you can make informed decisions once you have counts.
Now, it's interesting. You like the Santa Clara test because some people have really gone after it.
I like the concept of the Santa Clara test. As a test itself, everything is done hastily nowadays, and everything is done cutting corners to get information out. The Santa Clara test had issues with it. I get paid to pick flaws in everything. This is what I do. I get paid to find a disease in somebody, and I get paid to break apart tests, basically in newspaper or journal articles. Yes. So I think the test was an important, very, very good step. I applaud their public health department for doing that concept. I applaud them for getting out, putting good shoe leather epidemiology, putting your people into the field and testing. And I think that's great. I think it showed a real big light on the idea that there can be a lot of people in the community that have had exposure to this virus, and maybe we are at a shot of seeing this disease having a lower case fatality rate, which would be great. That would be great. Everybody wants this. I think it opened the door, and it showed that there's science behind it. And I think we need to expand on that. They were the first step into a dark room with a tiny light. And I love that they were brave enough and bold enough to do that. But we need to get more light in that room now.
True. Me too. And I thought that was bold. I know there are people who are like, oh, they recruited people from Facebook and they did this and they did that. But at the same time, they use the resources available to them to answer that initial question, like you said, to find that corner of the table. So now people can start really mapping the table, right?
Yeah, that's it. It raised the idea that it's possible. When the first person ran and broke the 5-minute mile, nobody even thought that was humanly possible. The same with the sonic sound barrier. Nobody thought that was possible. This is now showing there is some evidence and scientific plausibility that we should expand this testing in this arena.
Yes.
And it was one county, and you can always throw stones retrospectively at this. Trust me, I do it for a living. But the idea is that it's good. And I think that shows we need to be putting more effort and resources into this.
Yeah. So we have some questions. Susan Duncan Lindsay says, so if she or none of her family haven't been sick, would they still get tested? And do you foresee testing becoming mandatory?
That's a great question. I would, at this point now, with a paucity of tests, I would say no. If you're well and you're healthy and you're buttoned up and locked in tight, which hopefully you are, ma'am, I would encourage you to not get tested. We have guidelines right now about tiers or priorities of people we want to test. We want to test first hospitalized sick patients. We want to test healthcare workers who are showing symptoms. Secondly, we want to test people in long-term healthcare facilities, like assisted living facilities. We want to test our vulnerable people with comorbidities. We want to test our elderly population, 65 and older. We want to test our first responders. The well and worried, they are a lower priority. I do foresee us all, I'm a well and worried as well, ma'am.
Yes.
So I feel you on that. But, I do see us all being able to get tested in the future. I don't foresee it being mandatory. I think anytime public health starts to extend its arm into forcing somebody to do something, that's a dangerous thing. And I'm cautious of this. As far as I know, there's only one really, that's tuberculosis for multi-drug resistant TB. But I don't think it'll be mandatory. I think it'll be highly encouraged. And I think there will be benefits to you to know, are you a carrier? Are you resistant to it? I think you're going to want to know in the future, ma'am.
Yeah. Now, speaking of that, I did get a question by email. And the question was, do you foresee people like airlines? And we saw, for example, I think it's Emirates Airlines has now started screening. I don't know that they're testing, but they're screening people before they board flights. Do you foresee long-haul flights and airlines that do long-haul flights, the 12 plus hours of flight time, requesting that people bring their testing results with them before they can board a flight? That was the question I got from a travel blogger.
That's an awesome question. When I travel around the world, I carry a yellow card given to me by the World Health Organization that keeps track of my vaccines, keeps track of if I've had my meningitis vaccines, keeps track of my yellow fever vaccine, and if I'm allowed to go into countries or leave countries, plus or minus that yellow fever vaccine. So we're doing this now with border control checkpoints and health security of nations. So we're doing this now with certain vaccine preventable diseases. Yeah, I do see that as a likely and viable pathway in the future of, I had this conversation earlier today here in Las Vegas where I live. You want to get a ticket to go see the Ariana Grande concert. Well, here's your ticket. As you go in, I give them my ticket and I flash something, or I show my passport of health that shows
your antibody.
I've got an antibody, or I've been vaccinated, and I'm now able to go in and enjoy that concert, that gathering, whatever it is you choose to go into.
And it's important that people hear that, because that may be part of the new normal. It is. You need to show that, and because I know there are people who are itching to get back on their vacations, their travels, travel blogging, and etc. That's a whole industry, and right now it's and so at this person wanted to know, am I going to not be able to check into a hotel if I don't show this, etc.? And I don't know how far that will extend to, but it definitely makes sense. Dr. Faith B. Israel, she's a doctor of public health. She says, great information. Thanks for doing this, Dr. Cindy and Dr. Erik. Dr. Amy Evazadeh, she says, no, thank you. I think it's when you were describing the, bronchial aspirate.
Yeah.
And, now, since you're here and you are an emergency medicine doctor by training, since we're here, how can someone prepare themselves for a nasopharyngeal swab? What can they do to make it less uncomfortable? How should they prepare themselves, if at all, if there's a way?
I think with all these types of procedures, it's relaxing. It's taking a deep breath. It's going to be unpleasant. And I think getting into a position that helps, listen to your nurse, listen to your doctor, listen to your medical assistant who's testing you. They're going to ask you to get up into this kind of a sniffing position. They're going to ask you to kind of move your head around, and they're going to pop it in and out. They don't like doing it any more than you like getting it. Trust me, you're going to get stuff coughed into your face. It's unpleasant to do it. I do it a lot to kids in my practice. Mm-hmm. So I understand that. But I think the biggest one is to listen to the advice of the tester, because they do hundreds of these a day. They're going to know. They're going to make it as easy for you as possible. And I think it's just relaxing. It's going to last a second or two, and then it's done. And that's it. It's much less than a lot of other medical procedures. It's not a colonoscopy, or it's not an endoscopy, for the love of Pete.
It's not a PAP.
It's not a PAP, for the love of Pete, right there. It's not that bad. It's I always tell the kids that I'm going in and I'm going to pick out a really big booger. Hold your breath. 1, 2, 3. I got it. And then I'm out, type of a thing. So, yeah, it's fast. It is fast. Okay, go ahead.
So Mackenzie's asking, what about tracheal aspirate versus nasopharyngeal is what I think she's referring to.
Yeah, no, that's a good question. There were two papers that were really
as far as false negatives, so she added to it.
Good question. Okay, so there were two really seminal papers that looked at this. One kind of compared oropharyngeal and nasopharyngeal swabs. Oropharyngeal is just going in through the mouth to the back of the throat, or going in through the nose to the back of the throat. And there were two papers, and the first paper that came out really showed no real efficacy or no real difference between the two. But it was a small sample size. There weren't a lot of people in the study, so it was prone to some miscalculation just because of a small number. The second paper really stretched its legs. It had a lot more people involved in the sample size, and it showed that the nasopharyngeal swab is giving you a lot more true positives, which is what we're really looking for.
So nasopharyngeal gives you more true positives.
It gives you more true positives and less false negatives. It's hitting both. I believe I wouldn't bother, because both are unpleasant.
Yeah.
For me, I would want the most bang for my buck. And that's going to be in that nasopharyngeal swab. That is the way I would take it personally.
Awesome. Cora, for you, Dr. Erik, she says, great information, doctor. We are better for it.
Thank you, ma'am.
Yes.
I appreciate it.
And she also says we need to test to gain success. Oh, she's rhyming. Look at her.
I love that.
We have a long one here from Marilyn. She says, I have a friend who was ill about 3 weeks ago. She thought it was the flu, however, did exhibit some of the symptoms of COVID-19. She recovered in a few days after using home remedies. She tested positive a few days ago after several weeks. So it sounds like at least 3 weeks, and was told to self-quarantine for 7 days. Should she go do another test thereafter to prove she's negative? So they're asking for test of cure, I guess, basically.
Yeah, yes, that's exactly what we call it, as a test of cure. I'm going to ask right now at this stage, why does it matter?
Yeah.
All right. And this is going to be my question, because as a doctor, I don't ever want to do a test unless it gives me something that changes the management of my patient. I'm not going to put my patient through the uncomfortable nature of the test. I'm not going to spend the time, the money, the hassle of the test unless it's going to really change what I do. Yeah. She's got a positive. Now, the thing that I would like her to encourage to get is that serology test,
the antibody,
the IgM and the IgG, the antibody test. Now, that is a test that I would love to see her get.
Yes.
Yes.
And because it's interesting, right? She says her symptoms were resolved. So it kind of points to what we've been seeing, which is they say you can see the viral RNA up to 21 to 40 plus days after the symptoms have cleared. And it sounds like that's what's going on with her friend. So, and yes, I agree with you. Antibody testing would be the next best step. So if she's getting a test, Marilyn, then it should be hopefully the antibody test is what they're following with. Odette wrote, that's why it is recommended that we use the test the WHO recommends. I think she said this in response to what you were talking about with that sort of antigen test that the WHO is still validating.
Yes. Yeah. And I'm going to challenge the question for the previous questioner that was that a true false negative that she had in the beginning where she got tested? And I think she got tested and didn't, and had maybe a false negative on that test. Maybe she had a bad test that didn't show up properly.
So thought she had the flu. She recovered before she was tested. It looks like she sort of stayed home, and ultimately, like 3 weeks later after symptoms, she was tested positive and still told to quarantine, and then quarantine for 7 days. And the 7 days is interesting. I'm not sure where that's coming from. Do you have any thought on that?
The advice that I typically give people is you self-quarantine until your symptoms have resolved, and then add on 3 days.
Okay, so I get the because she was symptom-free already.
Yes. And now this raises the question of, did she have the flu 3 weeks before, or did she have SARS-CoV-2, COVID-19? Did she have COVID-19? We don't know what she had when she was sick 3 weeks before.
True.
And maybe she got a new infection of SARS-CoV-2 during that interim period, and she's asymptomatic.
True. And that's probably what's going on there. It could very well be that as well. That is true. Marilyn also writes, I remember reading some info about one of the latest added symptoms of COVID-19 being a rash. Is this true? We've actually been talking about this, Dr. Erik, a lot of the dermatologic things that are coming out now. But I'll let you answer this. Again, as an emergency medicine family practitioner, also public health epidemiologist, I'd let you address this because I know we're all fascinated by this one.
Right. No, the short answer is no. I typically do not associate rashes with COVID-19. There is good literature coming from our ophthalmology colleagues that is looking at conjunctivitis and redness of the eyes as being one of the issues of a harbinger of the disease. We also see anosmia, the lack of smell, being one of the potential verifiers that you could have that index of suspicion for SARS-CoV-2. I do not associate the rash with being part of a classic presentation. Now, this raises an interesting point that we're seeing a lot of myths and rumors and little whispers of microemboli or microthrombotic disease that is causing strokes or blood clots being formed as part of the pathology of this disease.
Yes.
We all know that there's a certain type of a rash called petechiae.
Yes.
I went to med school in England, so I probably say things weird. I'm sorry.
No, that's a good word. I would say that way.
That is called petechiae, like you see where you get clotting problems in your blood, and it's actually not a rash like you see with measles or chickenpox. This is actually little tiny pinprick hemorrhages in your skin. Now, I'm not saying that the SARS-CoV-2 virus causes this, but as we start to explore and learn about this disease, I believe you're going to see lots and lots of other symptoms that we're going to put together this picture. And then we're going to have a really clear case definition. And that's what's so important.
But right now, rash in and of itself is not what we're seeing. No. But petechiae that look like, if to the untrained eye, you might think it's a rash because you just see this pattern on your arm. Patsy says, thank you for educating us. Sasha says, glad you said that. Can you explain herd immunity for us in detail?
Yes. So herd immunity is awesome. Herd immunity is what allows us to protect the vulnerable in our population, the young, the elderly, the people that cannot get vaccines for whatever reason, whether they have an allergy to it or they have bad reactions in the past to the vaccines. So this is best understood with the concept of a vaccine. All right. Yeah. So if you take a disease that is very, very contagious, let's use measles as an example, one of the most contagious diseases I can think of.
Yes, and deadly.
Deadly. So if you vaccinate, let's say you've got a town of 100 people in your town, and you've got little kids in your town that are under the age that they can safely be vaccinated with the MMR vaccine. Mm-hmm. So they're at risk. No matter what you do, they can get measles. And you've got people that can't take the vaccine for whatever reason. Maybe they have a problem with their immune system. Maybe they're pregnant. Maybe they've got all these things, but they can't get the vaccine. So you've got 5 of them in your town of 100 people. If we vaccinate the heck out of that town and 95 of them are protected, those 5 should be guarded by that wall of immunity around them in their community, because nobody's going to get it, and I'm not going to be able to then give it to them.
Yes, so that's herd immunity. And so that's really the goal here. But what do you say to the people who've been saying, well, that's why we need to get people back out in the community. Let's just open up schools, send people back to the movie theaters, to the casinos. You know, you're here in Vegas, so you know we've had some famous people recently saying, just put them all back out there. We've
marvelous, yes, yes, ma'am. You know, I do see herd immunity as a viable way to go. Again, I want to test. I want you to prove it to me. You know, show me the money, show me the test. Right now, we're looking at case fatality rates that are anywhere from less than 1, you know, a 0.08 case fatality rate or a 0.8 case fatality rate up to 3. Now, if you take this population, let's go back to our town of 100 people. All right. If I've got a case fatality rate of 3, that means 3 people in my town are going to die. They're going to die. They get this, they get my disease, they're going to die. All right. And I've got to get 80% or 90% of my population to immunity. Right. So I'm going to need to write off those people as a casualty of this illness. I'm not willing to write off my mom. I'm not willing to write off some people with compromised immune systems, or people that have obesity, or people that have hypertension, or people that have these comorbidities we're seeing that have worse outcomes. I think that herd immunity is a great goal to go for, but you need to show me that case fatality. You need to show me how prevalent it is in the community with testing. And then we need to make sure that our hospitals have the capacity to handle a surge.
And that's the key, is the capacity. So that brings me to another question that I was going to ask you anyway, which is, you know, we're here in Vegas, so this one comes to mind, which is a lot of our casinos allow smoking indoors. Yet we know that smoking can lead to compromised respiratory clearance and all that stuff. Would you think that in the era where we don't yet have herd immunity, do not yet have a vaccine, that smoking indoors en masse should be restricted? You're
asking a public health doctor. I think smoking's horrible. I mean, you know, I don't smoke. Smoking is bad. You know, we all know that you have to live in a cave to not know smoking is bad for you. You know, smoking is a good binder of your virus particles that goes out into the air, that drifts around, and it increases communicability. I think smoking should be banned in public areas. I think smoking should not be allowed in buildings. I think unmasking to smoke, well, you're touching your cigarette, and then you're touching the table, and then you're touching your cigarette again, and you're touching your lips. This is a setup for horrible communication of infectious diseases. My goodness.
And that's something that worries me, because I've started hearing people talking about how the casinos are going to reopen. They're going to have fancy scanners looking at body temperature, etc. But I haven't heard anyone talk about the smoking. And that concerns me, that if you're going to reopen these big places that have a lot of close contact, what about smoking? We have Patsy says, Dr. Cindy and Dr. Erik, I was tested positive for COVID-19 5 weeks ago and recovered and returned to work. I work at a hospital that has a lot of COVID patients. I'm very concerned about getting reinfected. I'm in the process of getting an antibody test.
That's awesome. You know, first, awesome. rock on for working in a hospital with those COVID patients.
Thank you, Patsy, for your service.
You're awesome. The fact that you got sick and you kept going back in there for your patients is, man, you're a hero. It inspires me.
Yes.
Be careful. I have not yet seen good demonstrable evidence that shows you're immune. You know, if we take a look at what we know from other coronaviruses, you know, you're going to get a period of immunity. You're going to get 8 months, 12, 14, 18, 24 months.
Yeah.
But it goes away. And, you know, that's what a concern. So the question is, one, do you have immunity? Just because you've got that IgG doesn't mean you've got immunity. And two, how long do you have immunity? So it could be a case of, well, you've got immunity for 3 months, 6 months, 8 months. And then do we need to boost you with a vaccine?
Right.
In the future, I wish I had an answer for you, Miss Patsy. I don't.
We don't know yet.
Wear your mask.
Thank you. I think that's for us saying, you know, thank you for your service. But that's a really good point, because right now, I think most people are under the assumption that if their antibody test is positive, like you alluded to earlier, they now have a green light to mingle, not wear a mask, get out there, go to parties, go to events, congregate. And we don't know this. Really, 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 people, the science, you need to allow the science, and it takes time for us to really get that answer. And of course, Dr. Erik, you've taught me this. Let science lead as we go forward. Trust, but validate. Yeah. And we haven't validated this whole herd immunity thing yet, nor have we validated this lasting immunity question yet. Right.
You know, it raises good questions about. I like tropical medicine. Yeah. And there's a virus called dengue. Yeah. That is there's 4 types of dengue virus. All right. And the problem with dengue is you get one first strain of it, and you get some muscle aches and a runny nose and a little bit of a rash, and it goes away. But you get dengue a second time, and you have now an increased chance of progressing to a hemorrhagic problem where you bleed uncontrollably out of all the holes in your body. It's horrible. Mm-hmm. So we don't know, and I'm not saying that SARS-CoV-2 does something like a dengue hemorrhagic fever with that second co-infection or the third stacking on sequentially. But we don't know this yet. There are so many things we just don't know. The reinfection could be more immune response generating than the first. And this is what we're seeing is it's the immune response a few days, weeks later after the initial infection that is causing all the problems, all the mortalities associated with this robust immune response.
True.
And I've yet to see good data that says, 1, you're immune, and 2, that second round, if you get it, isn't the one that makes it even worse.
Even worse. No, we don't have that yet. And I think it's important because I know our society is eager to just stop having to stay indoors. They're eager to get back to their lives, but we still need some time. And unfortunately, the scientists, we're not saying this just because we don't like seeing people on the street. We're not that antisocial. We really, we really just want us to be safe. And like you said, none of us are willing to sacrifice our mom, our dad, nor are we willing to sacrifice your own parents or your own family members.
And this is a good one. I'm not an economist.
Yes.
And I see that need to temper paychecks, affording food, rent, things like this. And there are a lot of difficult decisions ahead. Yes. I do believe that there are certain parts of the country, one of my favorite sayings was Montana saying that they've been social distancing for the last 150 years.
Sure.
And, I like this in the fact that if there are certain areas that are meeting some of these criteria already. There are certain ways that you can go about safely opening cracks in doors and testing as you open the doors with the ability, like a turtle, to slam back into your shell and get protected if you need to.
Exactly.
But you got to have those dashboard lights up and running. And if they start blinking and your tests are showing problems, you got to be able to suck back into your shell.
Indeed. You got to be able to. The only way we do it is the test.
Mm-hmm. Yeah.
Shasha said, and I think Shasha's a nurse, if I'm not mistaken, because she's been interacting with us for a while. She says, glad you mentioned clots earlier. Yeah, she actually wrote it here. Look at this. As a nurse on a COVID unit, we have seen lots of pulmonary embolisms. Yeah. Can you explain that?
No, I can't. First, thank you for your work. You're awesome. I mean, the COVID nurses are the best.
Yeah, she's a New York City COVID nurse.
A lot of respect to you, man. That's really awesome. I wish I could tell you why. I don't. I benefit from having a lot of friends from residency who are these whiz-bang genius ICU doctors and pulmonologists, and these people are struggling to understand it still too.
Yeah.
I believe that this disease is affecting your clotting cascade, and I believe this disease is affecting the membranes on your red blood cells. Mm-hmm. Okay. I don't understand how.
As an endothelitis suggests.
Yes. Yeah. Yes. An endotheliitis, a vasculitis. Yes. And I'm unsure if it's on the red blood cell surface membrane or if it's on the lining of the arterioles or venules. So I believe that there is a lot more to understand with this effect on, calcrine and the clotting cascade and all these things. I'm lucky that I have a couple hematology friends that I ask them and I say, hey, Hardeep, what do you think about this? And the response I get is, I don't know, Erik. I'm learning. I'm reading too. And you're seeing a lot of treatment protocols now involving alteplase, streptokinase, increased doses of Lovenox and enoxaparin, unfractionated heparins. It's interesting, and I'm waiting to see, are these patients having better outcomes? We're gathering the data.
So those are all basically blood thinners.
Yes.
Increased use of blood thinners in the intensive care unit for these patients. Yeah. Very interesting.
And I'm seeing a lot of good protocols of these patients when they're getting, because, some of the screening on these are increased. One of the tests we look at clotting in the emergency departments and hospitals is called a D-dimer.
Yeah.
And we're seeing really sky-high D-dimers. So we know that this is measuring what happens when red blood cells get torn apart. We're seeing the evidence of these shells of these torn up red blood cells with these D-dimer tests. These patients are actually being sent home on oral anticoagulants, like novel anticoagulants that, well, I guess they're not so novel anymore. They're called DOACs, oral anticoagulation therapy to prevent them in the future. I'm anxious to see the studies on if these people are having better outcomes. Time will tell.
That's going to be huge, actually. Sunflower says, my test came back negative. Should I be tested again after 14 days of my testing?
I'm going to ask you why.
Yeah.
Are you showing symptoms? Do you have a reason that shows, I'm a hypochondriac and I don't test myself every day for every disease under the sun. I'd like to, but you need to get on with your life and you need to look at, what are you going to gain from this? And what kind of test do you want to get? So if you came back negative on your first test and you're still showing symptoms, are you one of those people? Are you a hospitalized patient? Are you a patient that's a frontline healthcare worker showing symptoms? If you're asymptomatic, you know what I would love to see you get? I'm going to talk about that serology test again, that IgG and IgM. I'd love to see you get that. But the swab in the nose again, if you're an asymptomatic woman, I don't see a need for that. No, ma'am, I don't.
I agree with you. So let's go through some of our take-home points here. One being that there are multiple tests out there. The gold standard testing you're recommending, Dr. Erik, is if you're having symptoms, let's go through the different scenarios. If you have symptoms, what's the gold standard test? Well, not gold standard, but most recommended.
The gold standard for immediately showing symptoms is you're going to want that nucleic acid amplification. You're going to want the swab into the back of the oropharynx through the nose that's going to show you've got the virus. And we're getting better on these tests, and that would be the first one I would suggest for you.
Let's say you're someone living at home with people who tested positive. You still seem to be doing okay, but you're concerned. What tests, if there are tests available, what should you get?
I believe if you're in close contact and you've had contact and caring for these SARS-CoV-2 patients, I think you're a good candidate for the nucleic acid amplification test as well.
So the nasal
I would do the nasal swab in the back of the throat through the nose. Yes, ma'am. I would test all those patients, even if you're showing asymptomatic, but you're in close proximity, you're quarantined, husband or wife with a known patient, because I'm sad to say, It's only a matter of time, I believe, until you get it.
Yes.
You know, all we're trying to do is control the crash on this, and all that isolation in your own house. I can't isolate as good as I'd like to from my kids or my family. You know, passing the door, food through a door, the door is still open. There's a crack under the door at the end of the day. You know, and if everybody gets asymptomatic and everybody has a healthy outcome, then I would really encourage people to start talking about that serology or antibody test.
Yes.
And that's going to be the most important one, because you probably have already had it if you're in that close contact and you just didn't show symptoms. You're one of the luckies that the 80% or so that was asymptomatic on that or mild symptoms.
What about the person who's been on quarantine at home? Well, not quarantine, but just home practicing physical distancing. Now they're about to go out to work, but they're scared. They're type 2 diabetic. They're in their 50s. They're in their 60s. They're hypertension. And they're scared to go back to work, but they know they need to go back to work. What do you tell that person?
I tell them, be careful. I tell them that only you can make this decision for yourself. I can't make that for you. As a doctor, I can educate you. I can tell you what these tests are going to show, plus or minus, if they're accurate or not. And I can tell you that you need to be taking care of yourself, and you need to practice good bread and butter public health hygiene. One, I encourage you to stay home. If you have the ability to stay home, explore these things with your employer about telecommuting into work, working from home. If you don't have that option, then I want you understanding putting on your mask. I want you understanding no fiddling with it and touching your face. I want you washing your hands. I want hand sanitizer all over. I want you wrapped in as much of a cocoon of protection as I can get for you out there, because I know you got to go back and you got to earn food and you got to earn money for your family. I respect that. But man, I want you to be as safe as you can, and I want you to stay away from people. You know, look at that 2-meter distance. Look at that 6 foot, 9 foot if you can get it.
Yes.
And I want you hands hygiene. I want you masking. I want you doing all these things to protect yourself.
Absolutely. That employer who's listening, who needs, for the sake of the viability of their business, wants to get started. They also want to help their staff members who need to keep working, but are also concerned about safety. What per se do you think, as in your role as a consultant? I mean, it's free advice now, but in your role as a consultant, as a public health consultant, how would you advise an employer, a clinic, a hospital, an ambulatory surgery setting, a supermarket, a hair salon or nail salon, because some states have said those are now essential?
Yeah.
What, if any, advice would you give to them, the employer?
You know, I empathize, and I understand this, and I think that we all want to get there. I think being pragmatic is important. I think you need to do it safely. I think, you know, we've seen lessons, and I'm not comparing this to the 1900 Spanish influenza pandemic, but we've seen those rebound curves coming back up after the lightening of social restrictions. And we don't want that. We don't want to open up for 4 days like Chinese movie theaters and then have to close back down after 4 days because we had another spot fire breakout.
Yes.
I think it's important to do it properly. I think it's important to do it with validated testing. And I think it's important to take care of your customers. I think it's important to take care of your employees. I think you have that duty to them. Don't ask them to work in an unsafe environment.
Yes.
I think you need to protect them. And I think that you can have all the social distancing precautions, the hand washing, the masks, but, you know, putting on my family medicine hat, man, I want to prevent things.
Yes.
I don't want anybody to get sick, because right now I can't tell you that you've got a 3% chance of dying or a less than a 0.5% chance of dying. I don't know. And I want to be able to look my patients in the eye and say, this is going to be what happens. And I just don't have the testing yet.
We don't. And it brings us back to your take-home message, which is you want everybody to remember. Tell us more about this.
You know, this is the maxim. If you're not testing, then you can't prove it's not happening. You know, absence of evidence doesn't mean that there is evidence against it. You need to be testing. I want you to prove it to me. I love the line from Austin Powers where he said, "I'm the Princess of Canada, but I don't have the papers to prove it." Don't believe me. Believe in science. Believe in your testing. Believe in showing that you have good immunity to this disease and you're going to be safe and healthy from a reinfection from a year. Yes. Believe that there are decreases of cases in your community. Believe that it's safe to go outside and shake a hand of your client or your neighbor without fear of everybody having this illness. And the way to do this is testing. Prove it to me. I'm a scientist. I want it to be proven to me.
Yeah. Last question for you, Dr. Erik. What's the first thing you're going to do when you find out your serology testing and feel comfortable that the downward part of the peak has finally started on the curve?
Well, like I'm allowed out of my house. I will probably take my family and my mom and my wife's parents, and I would really like to go outside, and I would like to go somewhere. I'd like to go to a restaurant. Yes. I really, we have a saying in my family is that we vote with our dollars. Yes. And I want to spend my money at a local mom and pop restaurant that really makes great food. I want to go to a place that I like. I want to sit down. I want to have a meal. I'm not cooking myself. I don't want to do the dishes afterwards. And I want to spend money on that local business. And I want them to know that I appreciate their sacrifices they made. I'm going to tip big, and I'm going to enjoy the meal outside. That's what I want to do.
I have to think of that. That's what I'm hoping for as well, really hoping for. So Dr. Erik, for those who watch you today, and you have been a wealth of information, and you have explained everything extremely well and very eloquently, where can you be followed or found if someone wanted to know more about Dr. Erik's work?
We have a website. We're at Adventure Doc on Twitter. And we have a website, adventuredoc.org, that is a personal project that I run with our team. And it looks a little bit about our global health work and some of the medical intelligence reports we generate, and a lot of the advice we give other people about how to stay healthy, whether you're an individual or a corporation or a federal entity. So that's a good way to get in touch with me if you have other questions. And I love talking about this stuff. I'm a public health geek at heart.
We love it, Dr. Erik. What is medical intelligence?
Medical intelligence is what you and I did today. We look at a lot of sources, and I make recommendations based on that about cholera outbreaks in Kampala, Uganda. And is it safe to go there? And if you do go there, how do you mitigate your company that's working there? How do you mitigate your diplomats that are overseas, your security services, things like that? So I generate reports based on health threats around the globe and help people traveling and working and living in those areas stay healthy.
Yes. So guys, this has been Dr. Erik McLaughlin, and he has been a wealth of information. I knew this was going to be great, and you did not disappoint. Despite our technical difficulties at the beginning, we made it. And I know that everybody's just so much better for it. Thank you so much for making the time, Doc. And do please stay safe. Continue growing your beautiful family. And we hope to see you on the show again.
I hope so as well, and I'd love to bring my junior epidemiology science team, Leo and Athena, my twins, out with me one time. And thank you for the opportunity to speak to your guests. You do a fantastic job of educating people, and thank you so much for the opportunity, ma'am. It was an honor.
Thank you. Bye, everyone. Happy Sunday.